My name's Louise Bamford. I'm here with Jake Garside and Chris Hyde. We are here to do Beth's ILS and assisting the senior clinician assessment. Beth, can you introduce yourself, please?
Yeah, my name's Elizabeth Finney, pin 50556, cohort 2405.
Thank you very much. So, happy is the wrong word probably. Are you all right to carry on with this assessment?
Yes, that's fine.
I will play the role of wife and then I will come in if you request paramedic backup to assist later on.
Okay.
You are attending a 55-year-old male. It was a witnessed collapse. Wife has started CPR straight away.
Okay, so I'm going to don my PPE. I'm going to start approaching the scene and do my DORA, checking for access, egress, anything that could cause a hazard to me, anything I can slip, trip, fall onto, and making sure there's no loose animals around as well. As I'm coming onto scene, I'm going to note the patient, the position, the colour, any catastrophic hemorrhage, and I can see that bystander CPR is in progress, so I'm going to contact EOC and let them know to get some backup running. Hello, it's the ambulance service.
Right.
Can you tell me what's happened?
Yeah, he just collapsed to the floor. It will make a cup of tea.
Right.
They told me to just press on his chest.
Right, okay. How old is he?
55.
Okay, are you wife?
Yeah.
Okay. If you could come off the chest for me for 1 second, I'm just going to expose the chest. And I'm going to check for responsiveness. Hello, can you hear me?
No response.
Check for a trap squeeze, for
No
pain.
response.
And then I'm going to do a look in using the cross finger technique. If there was anything in there, I'd use my gills or suction. I'm going to do C-spine check, have a look for mechanism of injury around.
No concerns.
Head tilt, chin lift, look, listen and feel for 10 seconds.
There's no rise and fall and you can't see anything, and there's no pulse present.
Okay, I'm going to contact EOC and let them know this is a confirmed cardiac arrest. Would you be able to get back on that chest for me, please? You're doing brilliantly. Now I'm going to attach my defib pads. I'll work around you for now, okay? You keep going, you're doing great. And if you could come off the chest for me, that's brilliant. And say well back for me.
Alright.
Do not touch the patient. Analyzing. No shock advised.
Okay, I'm just going to double check
Immediately
again for a
resume
pulse.
CPR.
No pulse.
Okay, so patient is in EEA. Could you carry on with that
Yeah.
chest compression for me? That's brilliant. I'm going to measure that mask up now to double check I've got that correct. And I'm going to start securing the airway as well. You're doing brilliantly, thank you. I'm going to do a tripod airway, measuring the OP from the jaw to the incisors, insert, invert, rotate, locate, measuring from the ear to the nose, beveled edge to the septum, twist, and I would have lubed them up as well if needed. I'm going to connect this to my oxygen, keeping it away from the defib as well, just in case we do need a shock. Turn it on to 15 litres, as this is a serious illness. Okay. And when you're ready, I can take over for you. Doing 2 rescue breaths. Setting it 30 to
Immediately
2.
resume CPR. 30 chest compressions, then 2 rescue breaths. Continue until patient is breathing normally.
Checking that there's rise and fall there as well. I'm scanning over over the body. Whilst I'm doing this, checking for any movement, any bleeding that I can see.
Do not touch the patient. Do not touch the patient. Analyzing.
Okay, so I can
Shock
see that
advised.
VT
Stand by your
is
patient.
showing.
Press orange
So
button.
before I shock, I'm going to check for a pulse.
And there is no pulse.
Shock advised, top, middle bod, everyone away, clear, oxygen away, looking at the patient, shocking.
Shock delivered. Immediately resume CPR. 30 chest compressions, then 2 rescue breaths. Continue until patient is breathing normally.
My name's Louise.
Hello.
I'll put this kit down
No
and
problem.
then I'll take a handover from you. So I'll come in on the next ventilations and take over. Thank you.
So this is a 55-year-old male, collapsed, wife was performing CPR, bystander, originally in PEA when we first came in, still no pulse, and has now gone into VT, 1 shock administered.
Great stuff, thank you. So we'll take over this.
Yep.
Are you alright setting me the airway kit dump up?
Yep, that's no
Thank you.
problem.
Pass that through and I'll
Yep.
plug it in for you.
That's
Thank
brilliant,
you.
thank you very much.
Lovely, so I'll do 5 ventilations. If
Yeah.
you could get me a size 3 blade ready and a 3i gel with enough lubrication on,
Yeah,
please.
that's no problem.
Thank you.
Say size 3 I
Yes,
gel.
please.
That's no problem.
Thank you. So 1, 2, 3, 4, 5, OP8. Thank you. I'll do that as well. Clear and gel in. Thank you. You alright for that?
I'll secure it
Cheers.
down for you as well.
Thank you. I'm not entirely sure it's in a great position, to be honest, that. There's no rise and fall. So I'll try and sort this out.
Okay,
If you get me the ET tube ready.
no problem.
Thank you. I'll probably go with size 6, please.
No problem. ET tube ready?
Okay. So if I ventilate again, then
Yeah.
if you pass the bougie,
Yeah.
are you alright putting the tube on top of the bougie when I'm in?
No problem.
Lovely. So 1, 2, 3, 4, 5, and ready for the bougie.
Bougie.
Thank you. Yeah, ready for the tube.
Tube going down.
Thank you. You got the
Bougie
bougie?
got the top.
Top. And tube pass through and bougie away. Thank you. ready for the airway treat, please?
Yeah.
Lovely, thank you. Are you alright to just secure it for me?
Yeah, that's no problem.
Thank you. Do you want me to open his mic?
If
It's a
you
bit.
could, that'd be brilliant. Thank you.
There we go. It's not the easiest of persons, eh?
Pass that on there. That's secured.
Thank you.
Just gonna
Oh,
tighten
lovely,
that.
thank you. And then I'll pass this over to you if you don't mind double checking the settings.
Yeah, no problem. So we've got alarm pressure set at 40, CVM on demand, no air mix, rest rate frequency at 12, tidal volume at 500, and I'll just connect this to the oxygen as well for you.
Thank you very much.
If you're on the vehicle, I'd connect it to the wall of oxygen in the vehicle.
Brilliant, thank you. So I'll finish up here if you wouldn't mind setting up the cannulation kit done.
No problem.
I'll get out of your way.
Yeah, ready? Where would you like your sharp spin?
In the middle, please, just in between his legs. Perfect. And can I have the tourniquet and a wiper, please?
Of course you can.
I'm looking at this, I'll probably go for a pink.
Yeah, that's no problem.
Thank you.
Do you want the pink in package or out?
Yeah, I'll have it in, thank you. Just as it comes. Not really, the gloves on, are they?
Is it?
And you'll stick to the sticker in a minute. Sharp away.
Would you like your flush or your sticker first?
I want the flush, please.
And I'm just gonna sharp away. Would you like the tap or would you like it?
No, I'll just have it as it is. Thank you
There
very
you go.
much, sir. And whenever you're ready, we'll fix it down.
Thank you very much.
Don't do much, do I, as a paramedic? You're right.
Yeah.
Let's get you some tissue.
I'd write the name and the date on
Yeah,
this, and
Great
then
stuff. Thank you.
place it on.
And when I flushed it, I wasn't too happy it was in the right position, so I think we'll just go IO
Okay.
straight off with that.
No problem.
If you wanted to use the same flush, you can do.
Yeah, that's brilliant. What needle would you like?
Have you got a blue?
I do.
I'll have a blue then, please.
And would you like to re-white?
Yes, please. Thank you. Fabulous. And whenever you're ready, three-way tap, please.
Yep.
Sharps away.
Just checking there's no bubbles in that. All good with that.
Looks good.
And I'll seal that off for you as well.
Thank you very much. Perfect. So while I'm just connecting this up, could you set me up an IV drug, please? For the purpose of this assessment, we have got IV water.
Okay.
So if you draw the whole 2 milliliters there for me.
Yep, that's no
Thank
problem.
you.
Put it away, securely the breaker on to the neck and pushing it away. And that goes in sharps.
And then just before you throw it, can we do the safety check?
Yep, that's no problem. So,
Water for injection, 125.
Yeah.
And it looks clear, thank you.
sharp away. And that's 2
Marvellous, thank you. We have witnessed you doing several of the fluid bags, so we're not going to ask you to do that again. So if you take a look at the chiller for me,
Yep.
have a look at the new rhythm, and then talk me through what you're thinking.
So this is looking like normal sinus rhythm or PEA.
So,
I'd have to check for a pulse to
Okay.
confirm whether it was PEA.
so when you check for a pulse, you find there is a pulse.
Mm-hmm.
So can you talk me through your reassessment of your patient?
Yeah, no problem. So we'd come back to the basics of airway, breathing, circulation. Start with the airway. Is the patient tolerating that airway still? If not, I'd get my para to remove the airway, check the rest rate, see if patient still needs us to assist with ventilations or if we can keep para pack on. Then to breathing, we'll check the SpO2, see what his stats are at. Make sure there's equal rise and fall in the chest again. Make sure that there's no blood loss. Do a blood pressure, do a cap refill, and check for what the heart rate's sitting at, as well as doing an ECG at that point. Then we go down to looking for our reversible causes, so temperature, what the GCS is sitting at now, a BM which we can get from the IO, and also do a pearl.
Great stuff, thank you very much. So you've quite rightly identified ROSC there, you've talked me through your reassessment, so I'll let you come off your legs and we'll come and have a seat over here. In fact, I think we can see each other there. So there's a few things that I want to ask you about. Just let me know if I'm not making much sense, and I'll reword it.
Yeah.
Alright, so can you tell me what the difference between basic life support is, intermediate life support and advanced life support.
So basic life support, anyone can do it. It's chest compressions and mouth to mouth if they know the patient. Intermediate life support is what we've just done with the more advanced airways and using the defib. And then advanced life support is where we introduce drugs such as adrenaline.
Lovely, thank you. So, while you're talking about that, can you tell me what the paramedic brought to that party?
The paramedic, unlike myself, I can only do an OP and an MP airway, whereas the paramedic can go on to IGELs and also ET tubes to secure the airway further.
Can you tell me the benefit of an ET tube over the tripod airway that you've used?
Yeah, so an ET tube can protect the lungs from aspiration if the patient does vomit.
Great stuff, thank you. So as well as the advanced airway your paramedic brought, what was the purpose? I mean, IV, IO, similar kind of thing, but what's the point in doing that? Why do they want it?
The purpose of an advanced airway rather than...
No, sorry, if we go on to IO and IV, what have we got that for?
So IV is to combat the possible hypovolemia. If the cause of the cardiac arrest is due to fluid loss, we can put that fluid back in. It's also an easy way to get drugs in.
Perfect, thank you very much. So your paramedics brought that, you've had a ROSC, your SP turns up on scene, what can they do differently?
They can administer post-ROSC adrenaline.
Great stuff, thank you very much. So you had your defib there in AED mode. What was the benefits of having it in AED mode?
So it keeps that rhythm for us, and also it analyses the rhythm and tells us when it advises a shock, whereas if it was in manual, it does give the clinician more of a choice over when they want to shock, and it also lets them set the joules.
Great stuff, yeah. Just a little bit quicker as well for them to make that decision. Well done. When would you not use an AED or a defib?
So we wouldn't use it around water, we wouldn't use it in explosive environments, and we wouldn't use it if we were connected or touching the patient at all.
Great stuff. And can you give me an example of when you might be connecting?
So for example, if we were connecting an IV, if we were touching the trolley of the patient that the patient was on as well.
Thank you very much. You did mention your reversible causes down there. Can you go through them for me?
Yeah, so we've got hypovolemia, fluid loss, hyperkalemia, which is your potassium levels. You've got hypothermia, your temperature, and you've got hypoxia, which is your reduction in oxygen. Your T's are your tension pneumothorax, which is a collapsed lung, tamponade, which is around fluid around the heart. You've got thrombus, which is a clot, which could cause an MI. And then you've got toxins, which might be an overdose.
Great stuff, thank you very much. So when would we choose not to start CPR?
So we wouldn't do CPR if we've been told not to by a doctor. If there's injuries incompatible with life, such as decapitation, massive cranial injuries, if there's been any incineration, if there's obvious rigor mortis and hemostasis in place, which is the pooling.
Thank you. What might they have that they might present to you as you get onto scene, which would say done?
A patient might have a DNAR in place as well.
Great stuff, thank you. So we did ALS on this patient. How long would we have to do it for before we decided to terminate the resource?
We'd have to do it for 30 minutes. It can be any rhythm in that 30 minutes, as long as the last rhythm is asystole for at least a minute.
Marvellous, thank you. And when else might we decide to terminate a resource?
If there's a new finding of a DNAR, or if a doctor comes onto scene and tells us we have to stop.
Marvellous, thank you. I'm happy that you've said what a senior clinician is with your SP and your AP and the skills that they bring to you. So we're just going to move on to modifications in a cardiac arrest now. If this person was 56 stone, what problems is that going to bring for you?
So a bariatric patient can have a more obstructed airway. We'd have to make sure that we're tipping the head back further to secure that airway. Also, ventilations, we might need 2 people to do those ventilations to get the oxygen in. CPR might be harder, so we'll need to rotate people more, and also we might need to press firmer, approximately 6 centimetres.
Great, thank you. So if you had a pregnant lady, what modifications would you have to make for her?
We'd consider the aorta, so we'd have to move pregnant belly to the left of the patient. We'd then go 2 to 3 centimetres up, and also we'd take mother is priority. We'd also, if we needed to fit defib pads and they weren't going in the correct places, we'd go on the ribs at the side.
Marvellous. So when you say 2 to 3 centimetres up, what did you mean by that?
From the normal point of where we do CPR,
right, okay,
2 to 3 centimetres up than we'd normally do.
Fabulous, thank you. So traumatic cardiac arrest. Can you tell me the HOT principles?
Yeah, so we've got hypovolemia, oxygenation, tamponade and tension pneumothorax.
Lovely. And what we're doing with time on scene with these patients? I'm just thinking, if you've maybe got a penetrating wound and we get to scene, what's the difference with whether we stay and play or whether we load and go?
So we need to stop that bleeding before we move the patient at all and before we start CPR. Yep,
well done. So stopping the bleeding, and then would we need to get going a little bit quicker than?
Yeah, I in all honesty, I'd probably refer to my paramedic at that point and let them take the lead on that.
Absolutely, well done. So you are unfortunate enough to get a drowning. So you have a patient who has come out of the water. What position do you need them in?
So we need to keep them as horizontal to maintain blood pressure stability.
Marvellous, thank you. And when they come out, potentially they're going to be quite cold. What temperature would you class them as being hypothermic?
We class hypothermia as below 35 degrees, but sometimes patients can show us below 30, which is just showing low on our temperature monitor.
Yeah, so it's difficult for us, isn't it? So when you do that, we have a difference with shocking. So after 3 shocks, what would we do if we thought the temperature was under 30?
So we'd be trying to warm the patient up at that point. However, after 3 shocks, that's the maximum amount that we can shock. And also we'd delay the drug infusion as well.
Great, thank you. And when they come out and they're really, really cold, what might that do to maybe the chest wall, and what effect will it have on your ventilations?
Ventilations and CPR will be a lot harder because of that stiffness, so we'll need to work a bit harder.
Lovely, thank you very much. Have you got any additional questions, Jake?
No, I think that was well covered, it was good.
Yes, it was very good, thank you very much. I'm going to stop your video now.